Thank you very much. Thank you for the invitation. And renal artery denervation is something that is coming back to the clinics, and I think this session is designed just to give you an information update where we are with the clinical program of renal artery denervation. Um, so, first of all, before I talk about this, I just want to introduce you the subject of hypertension. And the question is, why pursue device-based interventions for hypertension? So I think there are a few key things that I have mentioned here. Number one, hypertension as an unmet need is still undisputed. This is a problem that needs to be solved, and I'll show you in the next few slides what I mean by this. It has a high impact on patients, and what I mean here is that they need relief from lifelong pharmacy or therapy. Significant impact on healthcare providers for doctors and the hospitals. There is a reduction in cardiovascular mortality and morbidity. That is what we are looking for. The science behind renal denervation is very well established. I mean, we all know the role of sympathetic nervous system in blood pressure modulation, and also it is a very highly investable market for device manufacturers. So there is a commercial case for investing in this opportunity. Um, 1 in 3 adults have hypertension. That makes the total population of the world 1.2 billion people in the world have high blood pressure, which is astonishing. If you look at here, you have United States 75 million people, in Europe 81 million people, in the Middle East and the Gulf region you have 17 million people, and so in India 118 million and China 182 million. Together that's 1.2 billion people have hypertension, and it is projected to increase to 1.6 billion in the next 6 years, which is quite amazing. So you see here there is nearly 30% of the people today have hypertension globally, and that is to increase by 1.6 billion in the next 6 years to nearly 30% of the population. Hypertension is a key risk factor for cardiovascular disease, regardless of age, ethnic background, or gender. We see that there is significant increase in coronary artery disease, stroke, peripheral arterial disease, and heart failure in patients who have uncontrolled hypertension as compared to people whose blood pressure is quite controlled. Just 2 slides on the background of the science behind renal artery denervation. We know that efferent sympathetic renal activity causes a decrease in renal blood flow, decreases GFR, increases renal tubular sodium and water reabsorption, and increased renin release. So we know physiologically that all these parameters do happen, and in this graph you can see the level of stimulation. So you have low level, medium, and high level, and each level of stimulation we see a significant increase in the plasma renin activity, reduction in GFR, reduction in blood flow, and there is an increased sodium retention. So what happened to renal artery denervation? The device was launched in 2010 or 2011 when Medtronic acquired a small startup called RDM, and that was a technology trigger with hypertension 1. There was an exaggerated expectation from the trial. Hypertension 1 and hypertension 2 showed very positive results, but the expectations were too exaggerated, and that led to a despondency or a disillusionment with hypertension with the hypertension 3 results. And since then, there has been progress made in further proof of concept trials, and now we are trying to follow the evidence given to us through science. So I'm going to talk a little bit about what went wrong in hypertension 3 and where we are with the clinical trial program. So this was the blood pressure reading that we saw when the HDN3 came out in a few years ago. We saw that there was a no significant difference between renal denervation and the control arm, and it was largely due to a significant source of variation that was not controlled for, and I'll explain that to you in a minute. These patients were resistant hypertensive patients. They were on maximum antihypertensive medications, and there was no plasma or urine testing for or compliance or drug adherence. So this result underscores that a sham controlled trial was essential at the proof of concept stage. The power of placebo cannot be overemphasized. This trial highlighted the complex and multifactorial nature of hypertension and indicated that addressing only one aspect of the disease might not be sufficient. Early post-hoc analysis have shown multiple confounding factors or sources of variation. One of the key ones that we found was the use and change in hypertensive medications during the trial and adherence with the medication. Study population was another confounding factor, and procedural methods. When we started doing renal denervation, we were ablating the main arteries only, and we were focusing on the ostium. But now the procedure has completely changed based on science and preclinical evidence and the operator experience. So they were all confounding factors, but one of the key confounding factors was the use and change in hypertensive medication and their drug adherence. So in the trial, in the HTN3, we realized that there was 40% change in patient medication, and compliance was not checked for. There was no urine or plasma testing for compliance. And we know from all the studies that has been shown in parallel over the last few years that patients do not want to take their medication, and non-compliance is a big concern when we treat hypertension. So to overcome that, new trials have been designed after discussions with FDA and after talking to a number of clinicians, where we decided to take data when patients are off their medications so that we don't have a confounding effect of the medications. And we also wanted to do another trial when the patients were taking their medication, but they were standard medications and all the medications were standardized to 1 drug, 2 drug, or 3 drug. And there was a protocol given as to how these patients will be treated, and each medication will be added when it's necessary. There was no maximum dose titration, and adherence will be measured through urine and plasma testing. So we tried to cover all the variances that we have noticed in HTN3 in the proof of concept trials. The procedure has changed to reflect the renal nerve anatomy. So we know that when the nerves leave the spinal cord, they arborize towards the kidney. But it's important to see in this figure, which very nicely demonstrates that the nerves are a bit far away from the actual artery, and they arborize straight after when there is the bifurcation of the main artery. So most of these nerves come together or in more contact of the renal nerve when they come closer towards the bifurcation. So that's an important point that we didn't know at the time when we were doing the HTN3. Also, in the HTN3, we did not treat anybody with accessory arteries. Nearly 30 to 40% of the population has accessory arteries. I'm involved in currently in the pivotal trial on Spiral OffMed, and in my personal practice, I've seen that nearly 60-70% of the people have accessory arteries, which are quite big in size and need to be treated. And if we don't treat them, we won't get the appropriate results that we're looking for. And this is just the preclinical data where we have evidence that now that if we treat the main artery, there is a 71% reduction in norepinephrine spillover. But when we treat the main artery and the bifurcation, we have a significantly more norepinephrine spillover, again indicating that there is a need to do more denervation more distally. This is just a number of clinical studies. These are not sham controlled, but they're just randomized studies, small number of patients, again in human subjects, signifying the importance of treating main artery and the side branches, rather than just the main branches. And we're getting better results in reduction of blood pressure. We have new advances in technology. So initially when HTN3 was carried out, that was mostly a flex, and now we have spiral, which has 4 electrodes. It's easy to advance into the renal artery, and we can get 4 ablations within 60 seconds. It's a 4 French catheter, and it goes over a standard coronary wire, and we have 60 seconds of ablations, and the vessel diameter range has to be between 3 and 8, so more than 3 millimeter and less than 8 millimeter in diameter. And it has an advanced algorithm that controls the delivery of the energy. So the initial founding trials, HTN1, HTN2, and HTN3, were really based on resistant hypertension. Like any other therapy, like we see in TAVI, we start treating high-risk patients, and then we go towards the intermediate risk and then eventually low risk. We were treating very high risk, very significantly raised blood pressures in the HTN1, HTN2, and 3, And now in the proof of concept trials, the population was changed to moderate hypertension, and also all the things, all the lessons that we learned, patients were being monitored more closely, especially for their drug adherence. This is the ongoing Spiral HTN pivotal trial, and in this is an off-med trial. In this trial, patients are either drug naive, that they're not on any medication, or their antihypertensives have been stopped. So there's a washout period of 4 weeks, and patients are tested for their that they have no drug in their bodies through urine and plasma testing. And there is a very strict criteria of blood pressure. So therefore, enrollment is quite difficult in this trial because the current criteria is that their office systolic blood pressure has to be more than 150 but less than 180. That means they cannot be resistant or difficult to control. So this is a moderate hypertension population. And their diastolic blood pressure has to be more than 90. But the systolic 24-hour blood pressure at their second visit has to be more than 140 systolic and less than 170. So there's a very specific criteria that we think defines moderate hypertension and non-resistant hypertension, and that is the criteria that is being used to enroll patients into this study. The same criteria is for the HTN on-med trial as well. And patients are excluded because we cannot perform renal denervation because of the renal anatomy, or they have renal stenosis or some other abnormality. eGFR has to be more than 45, and they should not be diabetic or uncontrolled type 2 diabetes as well. And there should not be no secondary cause of hypertension. So that's the current inclusion and exclusion criteria for the off-med pivotal trial. The efficacy and safety, the efficacy is really a 24-hour blood pressure monitor that has to be recorded at 3 months. And the secondary efficacy point is office blood pressure at 3 months. And we're also looking at the safety, like we have looked before, for any adverse effects like death, end-stage renal disease, vascular complications, or new renal artery stenosis of more than 70% at 1 month's time. And the on-med trial has exactly the same criteria, except that the patients are allowed to be on standard medication. That can be a thiazide diuretic, calcium channel blocker, ACE or ARB, and also allowed to be on a beta blocker. But they need to be on 1, 2, or 3 medications. And the blood pressure criteria is exactly the same as in the off-med, where they have to be more than systolic 150 and their ambulatory blood pressure has to be more than 140 and less than 170. So very specific criteria is used to enroll patients into these studies. Okay, so this is just a very simple chart. Sorry, let's go back one slide. Okay, sorry, it's not going back anyway. Maybe the time is up, is it? Okay. So here we can see that the negative trial for HDN3 and what has changed for the positive trial that we're seeing at the moment. We have resistant hypertension has changed to moderate hypertension. So the patient population has changed. The catheter has changed from flex to spiral or paradox. We are doing more ablations, and the location of ablation is now main and the distal branches. And the operators are a mixture of new and well-established operators. So all these changes have resulted in good outcomes that we're seeing in the proof of concept study that I'm going to talk about in the next presentation. So the Spiral HTN Global Clinical Program is built on the strong foundation of lessons learned from Simplicity HTN trials. The ongoing Spiral pivotal trial and the on-med trial will further strengthen this foundation, resulting the most complete and comprehensive clinical database supporting the safety and efficacy of renal denervation for uncontrolled hypertension using the Simplicity Spiral device. Thank you. We can have questions, sir. Thank you. No problem. So the next presentation is also, I'm just going to carry on and just talk a little bit about the clinical data that we have so far. Sorry, this is the same one? It's the next presentation? Yeah, there is a second one. Yeah, it's the same one actually, but I'm going to just go on it. Sorry. Yeah. So they're all together. So just give me 2 seconds and we'll get onto the last slides there. Yeah. All right. So over 6,000 patients have been treated in published trials, and they are divided between randomized sham-controlled studies, randomized studies with no sham, and real-world registries. So 6,000 patients have been treated with renal denervation. Most recently, the proof of concept trials are being published, which have been quite promising. They were designed to demonstrate the ability of renal denervation to influence blood pressure in uncontrolled hypertension, spiral hypertension, off-med trial, the evidence in the absence of antihypertensive medication, and the on-med trial, the evidence what we were looking for in the presence of antihypertensive medication. So these were the proof of concept trials that have been published earlier. There was no baseline difference between off-med and on-med between the RDN and the sham control. The blood pressures were nearly the same, and they were really well matched for BMI, diabetes, smoking, sleep apnea, peripheral arterial disease, and coronary artery disease. In the on-med, there was no difference in terms of the amount of medications they were taking. They were very well matched for 1, 2, and 3 classes of medication. The hypertension off-med trial is very similar to the pivotal trial that we're doing at the moment. The patients had a washout or they were not taking any medication. The clinical criteria that I explained before is exactly the same what it was for the proof of concept trial. The blood pressure has to be more than 150 office systolic, more than 90 diastolic, and the ambulatory has to be more than 140 but less than 170. Again, targeting the moderate hypertension patients. Patients were put on the table and they had a duodogram and a renal angiogram, and then they were enrolled or randomized into sham or renal denervation, and they got the procedure done. And after 3 months of their follow-up, once they have a repeat 24 blood pressure monitor, they were allowed to add in antihypertensive medications at that stage. So in the first trial that was published, there were 353 patients enrolled, but only 38 patients were treated in the renal denervation group and 42 patients were treated in the sham control. There was a lot of exclusion, as you do expect with such a very strict criteria with the blood pressure, office requirements, and blood pressure for the ambulatory requirements. So the good news was that we saw a significant reduction in blood pressure in the 24-hour systolic blood pressure, 24-hour diastolic blood pressure, office systolic, and office diastolic blood pressure. In all 4 of them, we saw a significant reduction in blood pressure. And this was an always-on effect that we saw in these patients, especially when there was, during the high-risk zone, that there was a clear difference between patients who were treated with the denervation as compared to patients who were treated, who were not treated with the sham control patients. The safety was excellent. We did not see any side effects, and you can see here, in terms of vascular complications, serum creatinine elevation, new onset of end-stage disease was 0 at follow-up in 3 months in the off-med trial. Very similarly, in the on-med trial, we had the same criteria as I've just explained, but patients were allowed to take controlled medications, thiazide diuretic, calcium channel blocker, ACE or ARD, and a beta blocker. Again, very strict criteria that is seen here in this slide. 467 patients were screened, but very small number were actually treated. 38 patients were treated in the renal denervation group, and 42 patients were treated in the sham control. Again, signifying that the criteria for inclusion into the trial was quite strict, and there was a lot of exclusion from 24-hour blood pressure monitor, and that the blood pressure has to be within that range. Again, a positive study, and all 4, 24-hour systolic blood pressure, diastolic, 24 diastolic, office systolic, and office diastolic blood pressure were all significantly reduced in the renal denervation group in comparison with the sham group. Like the off-med trial, the on-med trial also has an always-on effect, and there was a very clear difference that we saw in denervation when we recorded 24-hour readings for 24 hours. Again, a very safe trial. At 6 months, we did not see any side effects or any adverse effects during the trial for 6 months follow-up. So this is again a slide that repeats what I've just shown, that in addition to the 2 Medtronic spiral denervation sham control trials. There was a third sham control study which was conducted by Radiance HTN Solo Record, and again showing that in about 140 people who were randomized, there was a significant reduction with a ultrasound-based renal denervation, highlighting that the sham control trials are positive and the proof of concept is there for this therapy for further evaluation. So this is here we can see Simplicity HTN3 also showed a significant reduction in blood pressure, but there was a significant reduction in the sham group, which we did not see in the Spiral HTN arm of or the Radiant Solo, and that just shows you that if we control for the variance and look for adherence and make sure that the adherence is monitored and the titration is as per protocol, you get a significant result in these patients. The relative risk reduction, I mean, we know that if we reduce blood pressure by 10 millimeters of systolic, there is a significant benefit in terms of cardiovascular mortality, coronary artery disease, stroke, heart failure, and mortality, which is independent of baseline pressure and comorbidities. I'm just very briefly going to touch on a registry, Global Simplicity Registry, which is ongoing in parallel. We're still recruiting patients into this registry, which shows you a real life experience. To date, 2,800 people have been treated with Simplicity denervation with this therapy. Baseline characteristics, so all patients are here but they were further evaluated in the high-risk groups with resistant hypertension, elderly population, diabetics, isolated systolic hypertension, chronic kidney disease, and atrial fibrillation. And their baseline blood pressures are given here. And we saw that when we follow these patients for up to 3 years, there has been a significant reduction in office blood pressure and 24 blood pressure up to 3 years. Not all patients are being followed up because there's still studies ongoing, and we are following patients as they come to that particular time point. And we saw a significant reduction in the subpopulation analysis in resistant hypertension, in elderly population, and diabetic for office systolic blood pressure, and also in isolated systolic hypertension, CKD, and atrial fibrillation. So all the cohorts that we looked at, there was a significant reduction in blood pressure for office and also for 24-hour ambulatory blood pressure monitor. So there is evidence for real life experience in registries where all these subgroups have shown a reduction in blood pressure at up to 3 years follow-up. Most of these patients were treated with the initial catheter called Flex, but towards the end of the registry, patients have been now treated with a spiral catheter, and we see there is a significant reduction in the time that is needed to treat with the spiral because of the 4 electrodes. The contrast volume that is used is also less, and the time that is taken to treat is also significantly less. Very safe. One of the key things we've seen of the registry is that it's been very, very safe. There is 2% risk of end-stage renal disease, and which is 1.2% at 36 months. So we have now merits of different evidences. So we have seen that the office blood pressure in off-med, in on-med, and the real-world registry have all shown consistently a reduction in systolic and diastolic blood pressure. What does that mean? For off-med, it minimizes the confounding effect of the drugs or adherence. So we do it without drugs. The design is of great interest to the patients who are involved in the pivotal trial ourselves, and we see a huge amount of people coming in self-referring themselves for the procedure because they do not want to take medications for life. Rapid enrollment indicates patient preference. The on-med is more relevant clinically because patients will be on 1, 2, or 3 medication and they should stay on them. And this is an add-on treatment synergistically working with the medications. And the real world is really high-risk patients, patients who have multiple comorbidities, and it assesses the durability in the practice settings. So I think in summary, various quality randomized control trials as well as registries have demonstrated statistically significant and clinically relevant blood pressure reductions in the absence and presence of prescribed antihypertensive medications. Blood pressure reductions following renal denervation were present throughout the day and night, so that's an always on effect that we have shown you. There's no major safety events. So that's one of the key things we have seen in the last few years with the registry and lots of patients being treated, that it is quite a safe procedure. The ongoing randomized sham-controlled spiral HTN off and the pivotal trial is going to add more to this data. And the results of pivotal, we hope to have them ready for ACC in March this year. So we look forward to that. Thank you very much.